Hello. I am Dr. Celia Egan, and I am joined by one of my colleagues.
Hi, I'm Megan Mazar. I'm the nurse practitioner here at True Women's Health.
Thank you so much for joining us tonight. We wanted to provide an opportunity for all of our patients and maybe all of our non-patients out there to learn about the medicine class called the GLP-1s. They actually go by a bunch of different names: Ozempic, Wegovy, Manjaro, Zepbound. When I first started working with True Women's Health, no one really had heard of these medications, and it sort of was a really big stretch to explain what they were. And now I don't think a second goes by that we don't see something on the news or social media about these medications. And so now we're moving away from just educating on what they are to just trying to educate about what's real and what's not real.
I would agree. Yeah, we came from having scarce sort of knowledge and resources about them to now they're everywhere and all over the place, and sometimes just discerning about what's actual and factual and what's not so factual.
Yeah. And we really want to provide this space for anyone who's watching to ask us questions. That's why we're here, is for this to be interactive. None of this is meant to be sort of us just chattering on and on. Of course, we could do that all day, but please post your comments. We're here to answer them. So, how we wanted to get started is we love starting with a case, because I think this is, we put together a case about a patient named Jennifer, and it is a typical story of what we see pretty much all the time in our office. So Jennifer is a 49-year-old woman who's coming in to see us. She's kind of frustrated because she's been gaining weight, a lot of her midsection, even though she's still working out, she's still eating healthy, and she just doesn't get it. It's been about 15 pounds, not a ton, but a lot, specifically over the last 3 years. And now her BMI has crept up to 29. She's 49. She has no idea where her menstrual cycles are at because she has an IUD, and she hasn't had any vaginal bleeding from her IUD. So she has no idea if she's ovulating or still getting her periods, but she does know she's suffering from night sweats and some vaginal dryness, which has been really frustrating. In addition, she's like, I don't know if this is important or not, but I am irritable. My kids are driving me nuts more so than they did before. My husband's driving me nuts. His chewing is driving me nuts. I just can't. I'm super irritable. And this is a very common story that we hear about women coming into the office. And naturally, we will talk with her and we'll get some labs. And this is a lot of times what we see. We see sort of these slight rises of a woman's blood glucose. So let's say her blood glucose is 109, leaving her hemoglobin A1C, which is an average blood glucose, at 5.7. This would put her in the range of pre-diabetes. And for the first time ever, we're noting that her cholesterol levels have gone up. So we know that the lab, her LDL, which was formerly what we used to call the bad cholesterol, that's the one we like to be lower, sort of has crept up to 132. And of note, her other labs, her vitamin D is 24 because she lives in Michigan. And that's commonly what we see. Megan, is this a pretty good snapshot of what we see in the office?
It says a majority of patients that we see coming into our office. So this is a common scenario. And I think that for many women, this is incredibly impactful on their health, and they feel like they're alone and they're the only ones dealing with this, when in reality, truly, this is something that a lot of women are dealing with in this time of life, and something that can very easily be helped with the right course of treatment or changes to lifestyle.
Yeah. And I know there's a lot of women out there that are like, her BMI is 29, like I roll, like I'm struggling with obesity, right? My BMI is 35, 37. I would love to have a BMI of 29. And, we highlighted this just because we want to show this overlap between, our hormonal changes and weight gain. And that's where we want to start. So why would a woman gain weight? Whether she's 14, 40, 80, why does a woman gain weight? So we're going to pull up a slide that sort of is a good visual of why a woman would gain weight. So you have to remember, your fat cells are part of a really intricate system between your brain and the rest of your body about what's going on. And your brain is really the driver of trying to keep you alive, maybe trying to reproduce. And there's so many different factors that are at play. Forever, we sort of thought about those two at the periphery, right? diet and exercise as sort of being the only sort of markers of whether or not we're going to gain weight. The word that I used to hear all the time, and I still do, is burn. We're like, I need to burn more calories. I need to burn more because if I'm not burning, I'm storing. And what we've learned really over the last 15 to 10 years is that we're moving away from this concept of burning, but to messaging. And so if you look here, there's obviously a ton of different factors that are sort of influencing your brain that's providing this output, both not only of how your body's going to handle all the energy input that's there, but also what's driving our next decisions, such as like our ability to make a good choice about eating, how hungry you are, how easy it is to turn down a cookie or a sweet. All that is being driven by all these different factors. And so if you can imagine, here's your brain trying to keep us alive. We're going to flip to the next slide. This slide really highlights this messaging system. So one of the main functions of our body is to maintain an energy level, right? We got to make sure everything that's coming in is being sorted, manipulated, put into the right place and utilized at the right time. As you can imagine, there must be a good communication system between our brain, our liver, our GI tract, our muscles, our fat cells. And then we have this, I always make a joke, if the business of our body is staying alive, our side business is having babies, right? So our body will try to keep us alive at all costs, but we're always going to be ready for our side project as needed. And why that's so important is because you can imagine if you have this whole energy flow and communication system that's happening, if you get the cue that you're ovulating or pregnant, it's going to change a lot of different things. And this is just a lot of women will even say, even when they're in reproductive phase, when they have pretty consistent cycles every month, that time right before our period, we're getting lots of chocolate cravings. It's really hard to turn down those sweets. And maybe we'll gain, 3 or 4 pounds kind of out of nowhere. You got to imagine those hormonal shifts are part of this communication system. And so when we start talking about these drugs, what we're talking about is manipulating this really intricate system. And if we want to flip to the next slide.
I want to chime in here too, Celia, and just mention that I hear all the time about people coming in saying, my provider said calories in, calories out. And we really want to get away from that mentality because if you can imagine, just in this picture, the complexity of that, right? Like we know all these influences are happening. So it's very much more complex than the simple calories in and calories out.
And I would even, we try to simplify this a bit with this picture, but I would even argue that it's even more complicated than this. And one of the factors that is not really shown and highlighted in this picture actually is our microbiome. So our microbiome is all the bacteria that live in our GI tract. They're the first that sort of start digesting foods that we've eaten. They're the first to sort of trigger the intestinal cells to send out all that communication. And different environmental factors that we have, so in addition to changing our brain, can also change our microbiome, therefore sending off different ripple effects amongst this messaging system. And we've seen this in research studies where patients will have a massive switch of their microbiome for a different medical issue. And then all of a sudden they were someone who didn't struggle with extra weight, and now they would. And I would say I see this in the clinic a lot too, where sometimes women will make these small little pivots. Maybe it's a new medication, maybe it's a new diet, maybe it's even just like a new supplement. And all of a sudden we start kind of seeing their weight creep up. And my theory, of course, I can't prove this, but a lot of it is there's these shifts to their microbiome that are at play.
Yeah. And I think what we're learning is, and what I think you've known for many years is that, this is such a complex disease that I think we're actually giving it now the respect it deserves. Right?
Yes, absolutely. So. Okay, so we're going to flip to the next slide just to highlight if we're going to zoom in a bit on our brain. So remember, we thought about all those factors that are influencing our brain. The main part of our brain that we're thinking about is someplace called the hypothalamus. And the reason why I wanted to show this is because, we hear all the time when women come to see us, one of the complaints one of the reasons why they don't want to start a medication to help with weight is they'll say, I think it's like the easy way out, right? I can do this. I don't want to cheat, right? That's another common words that we use. And what I want to do to highlight this is to show you that your brain is there and it's getting all that outside influence, and it starts driving our ability to make different food choices. So even though your intentions are always in a good place, right? In a sense that you get it, healthy eating is a really important thing to do. You totally understand that donuts or that second donut is not a good idea, right? You understand a lot of this chemistry, but there may be something driving your brain to not allow you maybe just to stop at that one dinner plate, or maybe not to, drive by the gas station. There's something calling you to like slip into the gas station because you got to have that extra soda. And the way that these drugs work, and they work in many different ways, but one of the main ways that they work is at our brain to sort of turn around some of those hunger cues and those craving cues that get thrown off with, years of environmental and genetic factors that are at play. I think that it's really interesting as we learn more and more about these drugs. Another, this overlap too between healthy eating and alcohol, which is a really common thing that we hear when women will start some of these medications. They'll report that their desire for drinking alcohol also goes down.
It's interesting to see kind of some of the new research coming out in that area too, in terms of, decreasing alcohol use and with the use of GLP-1s. So exciting.
Yeah. And you can imagine, again, if this, the most animalistic part of our brain is sort of they're making decisions about what we're going to do next. I mean, it makes a ton of sense that those cravings for sugar and those cravings for alcohol sort of can overlap, and treating one can sort of have a ripple effect down the way.
Yeah.
So, as we get started, we kind of want to highlight sort of even what this class is. So this class of medications is essentially mimicking those messaging system or those molecules that leave our GI tract, and they go to a variety of different places. They go to our brain, our muscles, our liver, and they basically give the cue to our body that we have food coming in, we have energy coming in. So as you can imagine, it sets off that ripple effect of what your brain would do. Your brain feels less hungry, your liver runs a little bit more effectively, your muscles start taking up sugar. Our fat cells are like, I don't need to necessarily store any of this food. I can start to shrink because I'm getting the cue that we have tons of food coming in. And that's a lot of the times how this works. Now, there's newer medications that are coming out that are mimicking some of these other peptides, and we'll talk a little bit about some of the nuances of the new drugs, but in general, that's what we sort of see. So these drugs started out about, 10, 15 years, actually over 20 years ago in the field of type 2 diabetes. And forever, treatment of type 2 diabetes was really complicated with all these medicines that, one of the side effects was weight gain. I don't know if you saw that in your practice, like when we were just only giving maybe insulin or some other medications. And it felt like this terrible catch-22 that you had to either have controlled sugars or gain a bunch of weight. Yeah. Neither option really felt great.
Yeah. And then the more we would control their sugars, the more weight we would gain. And it was, it was a vicious cycle for a lot of patients.
Yeah. So these medications came about, and, a really pleasant side effect that we saw was that patients were also losing weight. And that was really obviously interesting to researchers and doctors. And so what they did is they started isolating some of these molecules and using them only in the weight loss field. So the first drug that was available, I don't know if we can pull up the slide looking at the semaglutide data. Actually, some of the, first drugs that were available were used daily. It was actually called liraglutide or Saxenda. We're not going to show that data because we actually rarely use it at all. So we're really going to just focus on some of the weekly injections that are mostly used in common day. So this is sort of the end result of the drug semaglutide. It is under the brand names of Ozempic for type 2 diabetes and Wegovy for the treatment of obesity, and then another slew of other medical problems like chronic kidney disease and recurrent heart attacks. But why we want to highlight some of these slides is you can see the difference. That top line is what they call the placebo, meaning patients were getting a subcutaneous injection of nothing. And then the bottom line is the patients who receive semaglutide. And you can see just this major split of weight loss over, I think it's 60 weeks, which was something that was honestly at this point in the weight management world, absolutely unheard of.
Correct. Yeah. Yeah. And I think we saw this in practice too. We had not had anything to date that was this effective, except for bariatric surgery.
Yeah.
Yeah.
And, a lot of bariatric surgery was sort of a hard sell. I don't know if you had those conversations with women. I mean, this is not to downplay bariatric surgery, because I do think that it was helpful for a group of women patients in general. But I think in general, bariatric surgery was really a hard sell, because we're talking about really going inside your body and manipulating organs, which was never really a great idea.
Yeah.
And one of the things that was a struggle for some of these patients is sometimes they would, a lot of times gain weight on the back end.
Mm-hmm.
We would see sometimes some weight gain after 3 to 5 years, when a lot of their cravings would come back, and, those hunger cues would come back. So even though they initially had lost like a good deal of weight, 3 to 5 years later, sometimes we would see some struggle. Not everybody, but sometimes.
Yeah.
So, first the drug that came out was semaglutide. And obviously from here, you can see the really a good weight loss result. And the average weight loss was about 16%. But we all know that we have family members, or even a personal story, where patients have lost up to 20, 30% on semaglutide. And if we want to flip to the other drug, tirzepatide. So this was the tirzepatide data. And Tracy, we're going to get your question. Thank you for asking. This was the tirzepatide data. So tirzepatide came out in about 2022, 2023. Time is flying. And it's under the brand name Mounjaro or Zepbound. So Mounjaro is for type 2 diabetes. And Zepbound is for obstructive sleep apnea and treatment of obesity. And what makes tirzepatide unique is, in addition to the GLP-1 molecule that's there, its addition of it actually hits on the secondary receptor of what they call GIP, or glucose insulin peptide. So it's one molecule that hits at these different receptors. And with that addition of that second sort of receptor update, we saw even more weight loss. So again, the top line, sort of in the top right-hand corner, is the placebo. And then the bottom lines are sort of the different doses of tirzepatide. And on average, patients lost about 20%. In practice, how often do we see a good deal of weight loss with Zepbound?
I was going to say, this has, again, by far even blown semaglutide out of the water, which we were also thrilled to have. So this has, again, offered even more weight loss. I mean, I'm seeing patients with 25, 30% weight loss even, just on tirzepatide alone, with lifestyle changes, which is incredible to see.
Yeah. Yeah. I mean, for a while in the obesity medicine world, we were almost like, this is too good to be true. Mm-hmm. Like, this can't possibly be the case. There must really be something wrong. And, every conference that I go to, they are combing the data, looking for a reason why these medications should not be used, because they're very concerned, obviously, that this just feels like it's too good to be true, that we can't have patients sort of losing so much weight. I will say, if you look down the bottom bar graphs, what those are the percentage of the patients that lost 5%, 10%, 25%. And one thing we see in the office is not everyone actually loses weight on these drugs. Mm-hmm. So these numbers are not 100%. And I know we have a good deal of women who are like, I'm on tirzepatide, I'm on full dose. Everyone in my family has lost weight, right? My friends, like, their weight is falling off, and like, mm-hmm. why not me? Mm-hmm. And that can feel so frustrating. But when you look at this data, you can see that it is not 100%. And I would say our practice sort of falls kind of right in line with this data.
I would agree. Yeah. And, I would say for those patients, or for people who are suffering with, inability to lose weight on tirzepatide, hold tight. There's more to come.
Yes.
And there's also other things to add, right? We know that there are a combination of things that can be helpful.
Yeah. Tracy, let's talk about your question. Are there any long-term safety studies? So, the longest studies now, these patients have been using this class of medication for like about 20 years in the type 2 diabetes world. The data that was presented in 2022 about tirzepatide, that was a collection of like 5 years of data. So, we're coming up to about 10 years of data with tirzepatide just from the initial studies. And then, the studies that came out in the STEP trials for semaglutide, oh my gosh, we're on, 12, 13 years of patients
13,
using these medications. So, although we don't have decades of data, we are moving longer and longer to amounts of time that people have been using these medications. I will say, even non-drug studies, that researchers are really trying to look at every angle of this and really trying, when we look at side effect profiles, we don't just look at some of the common side effects, which we can go into, but they're looking at infections, they're looking at cancers, they're looking at thyroid cancer. They're trying to find sort of, a reason why, these molecules would maybe trigger the wrong thing in our body and cause an issue. To date, we really haven't seen anything. And so when we talk about side effects, I sort of bucket side effects into two major groups. The first group is everything to do with our GI tract. So part of the response that these molecules give is they slow down our GI tract. So patients can feel nauseous, they can get constipated, reflux, and it tends to get worse like the more heavy foods that you eat. A lot of times even patients will start off, feeling well and they're doing well and they kind of forget that they're on a medication, and then they'll, go out to a restaurant or it'll be the holidays and they'll just kind of overdo it. And they're like, oh my goodness, there was a lot of nausea. So that's bucket one. The second bucket is essentially just not eating and drinking enough food, right? So we see women who just that hunger cue goes away. They're busy doing other things. They just have forgotten to eat and drink. And interesting, our thirst goes away, right? So if you, were thirsty that mid part of the day, you may not be thirsty for hours and just missing out on water throughout the day. And so that's where we see women have fatigue and hair loss and muscle mass loss and generally just kind of feel ick. A lot of the times we can work on finding a good balance with eating and a lot of those symptoms will go away. Not always, but a lot of the time. Tracy has a great question. What is the effect on mood? We've heard some patients develop a flat affect feeling of vanilla while they're on these medications.
I will say, Celia, you and I have both seen this. It's not common to see this, but there are a small amount of patients that while on GLP-1s, remember this is working on our brain, that, especially patients who really find a lot of joy with eating, and food is comfort, food is, releasing dopamine and happy chemicals, that as we bring that food noise down, that there can be some anhedonia or that vanilla blah feeling. And so that's something we monitor for. And if that's occurring, there's a few options. One is if you're on a higher dose, we can certainly bring the dose down to see if that is effective, or maybe switching medications if that happens.
Yeah. I've also seen this a little bit more frequently. I think early on in our management of these medications, I was sort of cranking the dose up really fast because, the FDA recommendations and part of the drug studies is that patients sort of dose escalate every month to like the max dose. And that's what I was doing. But what I found is the women who struggled the most with mood actually lost weight the fastest. And so, we've worked a lot in our practice of finding a good cadence of not losing weight too fast and really trying to find that, really comfort zone where your body and brain are okay with what are happening. Your fat cells secrete other hormones and they're doing other, being part of the other messaging system that isn't just the energy flow. So for instance, our fat cells also secrete estradiol, which is very interesting. And so some of the shift may be, changing some of the other hormonal systems that are at play. Great question though.
Yeah.
So we're going to go on to Sandy. Sandy said, I've heard there are sideshow positives that happen, heart, brain, being on tirzepatide. Let's talk about that. Sandy, thank you very much for this question. So, the two main focuses, the main foci, is that the right word?
Yes.
that come with using these drugs, the most studied have been, type 2 diabetes and obesity. But we've been so pleasantly surprised about all the weight-related co-conditions that have also gotten better. And there's very clear research, FDA approval research for heart disease, chronic kidney disease, obstructive sleep apnea, what we call metabolically associated steatotic hepatitis. It used to go by the name fatty liver disease. Essentially, your liver is inflamed because of fatty liver buildup. So yes, I think the overarching theme of all those co-conditions is there's something anti-inflammatory about these drugs. So, and I don't know if it's at the liver, if it's at the microbiome, but we're seeing it, one, play out in research studies, but two, just based off our experience of what we hear, that women are just, quote unquote, so much less inflamed.
Mm-hmm. Yeah, we hear that regularly from a joint standpoint. I have patients who suffer from, inflammatory bowel, who say the same thing, although that's not a clinical indication at this point for the medication. But just anecdotally, we're seeing amazing anti-inflammatory benefits from these medications.
There's currently a trial underway looking at the use of tirzepatide in combination with another immunomodulator for treatment of rheumatoid arthritis. Mm-hmm. So as you can see, they see that there's these anti-inflammatory properties, and we can see the decrease of inflammatory markers, particularly high sensitivity CRP, which is a marker that we draw in our office, at the blood vessels, at the airways. So there's very clearly some anti-inflammatory properties. And inflammation is what we believe is driving a lot of these chronic disease processes, heart disease, cancers, dementia. So, time will tell. And the problem is that those disease processes can take years to develop and present. And so we're all kind of waiting, for this long-term data that's coming out. I will say, I even had a patient today that I was thinking about, and we were debating between using some of the older oral agents, which are like phentermine, topiramate, fusimia, and a GLP-1. And I did sort of tip my mind to saying, this woman has maybe some heart disease, like maybe that's what we should use now, right? Yeah. Because of all the other anti-inflammatory and cardiac data that's there.
I think when we present women with the benefit of all of these medications, I think, honestly, it's a risk and benefit conversation like we always have in the office. But I think we're starting to see some clear indications for use of these in, most patients, right, that are suffering, right?
Yeah.
Most disease processes.
So, yes. And Misty Jo made a comment that her cardiologist has been very impressed with Wegovy. With the business that had made the company called Novo Discus that has made Wegovy, kind of saw that they weren't going to get quite the same weight loss numbers as the drug, Zepbound or tirzepatide. And they kind of made this pivot into, cardiac data. And so they spent a lot of their time and research dollars on trying to understand the role of semaglutide or Wegovy in heart disease. The most data is sort of around recurrent heart attacks, although I've seen sort of data where they've looked backwards and looked at risk factors, and what they saw were patients with high risk factors had less initial heart attacks, although, that is not the FDA indication. The FDA indication now is if you've had a heart attack, using Wegovy to help prevent a secondary heart attack. But, once the cardiologists get involved, I think everyone gets pretty excited, right? Because, preventing heart attacks just feels like something so amazing to sort of sink our teeth into. And it's something that we can all sort of get behind.
To touch on the second question of, we don't understand why insurance doesn't cover it. We don't either.
Misty Jo, I can't even.
Yeah, we could talk for hours on that. I wish we had better answers. So,
I can tell you, so, one of the things that we're running into is there's basically this insurance loophole that came from the 1970s where Medicare said that they weren't going to cover anything cosmetic. And when they were listing all the things cosmetic, weight management fell under that. So again, we're in the 1970s. We're not in the same place that we now are in the understanding. And, there's a lot of groups, the Obesity Action Coalition, the Obesity Society, that are working on trying to get that Medicare loophole closed, because it allows insurance companies to essentially pick and choose what they want to cover. So they can't do that for other things, right? So your insurance company can't say, if you go to the hospital with a heart attack, but not a car accident, we're not going to pay for that, right? They have to sort of cover everything that comes their way, except for these sort of odd loopholes. So we're working really hard on trying to get these loopholes closed. In terms of other disease processes like obstructive sleep apnea, liver disease, cardiac disease, it really, because there's other treatment options for some of these things, it really depends on your insurance company. And if and when you're picking out your insurance plan, you really want to look at those details carefully, because some insurance companies are providing it, but like the details of how they're covering it are very nuanced. And sometimes they'll say they'll cover it, but you have to have really strict criteria to get coverage. So you really want to be careful when looking at that.
Yeah. The navigation we know is it's very difficult, and I feel for patients, and it's just an awful system that we have right now. So we feel for everybody.
Yeah. And, we've been very excited because, as of July, Medicare sort of had an avenue to provide some coverage for some medications. We call it the Bridge program. We have been able to get sort of coverage for some of our Medicare patients that are have been struggling with obesity, have been struggling with some of those things. And that's been sort of really exciting.
Yes. Yeah. And hopefully that opens an avenue in the future for maybe commercial insurances.
Yes, absolutely.
Yeah.
So we're going to look at Jody's question. I've been on Mounjaro for 2 years and I lost 20% in the first year. No side effects. Amazing improvement, but never able to go above 7.5 in the dose because my doctor's concerned about my A1C being too low. I started to regain over the last 6 months, and food cues and noise are coming back. What can I do to get back on track and not lose the progress I've made? This is a really interesting scenario, Jody, and I'm intrigued. As far as I know, and Megan, please correct me if I'm wrong, I don't think that there is a lower limit of your hemoglobin A1C.
We just had this question come up the other day in clinic.
Yes.
Yes. I would agree. I think that I have a couple questions that come from this. Number one is, you mentioned Mounjaro, so I'm assuming we're using this for diabetes purposes, and we don't have to go into details, but that would be my assumption. I would look at nutrition pieces, right, to make sure that we're not having hypoglycemias or having too low of blood sugars. That would be my number one concern, making sure we're getting adequate nutrition. And that may also help with some of that food noise and cravings too. So from a nutritional lifestyle piece, but no, there isn't not a necessarily too low of a A1C limit to my knowledge either.
Yeah. So what is your hemoglobin A1C? Your hemoglobin A1C is looking at your red blood cells, and it's basically this measurement of these sugars around your red blood cells. And, as far as we know, there isn't a concern that that could go too low, because your body just doesn't work that way, in a sense that it's not going to have it dive too low based off of some of the cues that your body's getting. Now, you may not eat that much, and that may be a reason why not to sort of maybe increase the dose, and that may have been the concern. Right. But based off that number alone, I wouldn't say there was a reason. Now, about 10, 15 years ago, there was a study that came out that was a bit groundbreaking. And essentially, when we were treating type 2 diabetes, when the only tools that we had were, insulin, they basically found that the mortality rate went up as the lower people's blood sugars were. But what we were doing to get there was just giving people more and more insulin. Mm. So for a while in the type 2 diabetes world, we were like, we can't get people's sugars too low because the mortality rate's going to go up. But a lot of us, reflecting backwards, were like, I don't think it was necessarily that the sugar was too low. I think the insulin was too high, because we now know that hyperinsulinemia, or just basically too much insulin, can drive inflammation, can drive vascular disease. And so, I think some of that may be this interpretation that there's something wrong with having too low of blood sugars, and maybe that's an avenue that this doctor was going down. But to ask your, secondary question, a lot of times when we see women who have this return of cues, sometimes we do sort of reflect backwards on our lifestyle changes to say, hey, it's been so easy to make good food choices. Is there anything we can do about, honing in? The complete lack of food noise does start to come back after about 6 months. We do hear this a lot. It never goes back to where it was. It never, if your food noise was here and comes down to here, it will kind of take this tick up. It never goes quite as high as it was, but it will sort of take this tick back up. And you do need to rely on some of your older tools that you learned on to help stay healthy and sort of treat those food cues. If it really starts increasing, you can add in some of the oral medications. And a lot of that depends on some of your relationship with food. If you're having more emotional eating, Contrave is a great drug. If you're having more sugar cravings, Topiramate's a great drug. So you can add all those medications. I always, tell patients, in theory, you could take them all together, which we would never do necessarily, but you could. So I'm not worried about, starting any of those drugs, the older oral drugs on top of some of these newer drugs. So that could be a possible option to go on to sort of help you stay on track.
And just because I know we're probably going to get this question, we would not use an oral GLP-1 with an injectable GLP-1. Just to clarify
thank you.
That.
Actually, let's throw up we're kind of flipping around slides, but let's throw up the orgliflozin data.
Can we call it Foundeo?
Let's just call it Foundeo. We're going to go through some of these slides. Keep going in. No, it's a couple slides later. Here it is. Yay. Okay. So over the last about 18 months or so, what came onto the market was not just these molecules as subcutaneous injections, meaning you had to stick yourself with a needle to get the medication on board, but they came out as pills, and that came out in a couple of different levels of technology. So the drug semaglutide is now available as Wegovy, both as an injection and a pill. And then the company that makes tirzepatide does not have tirzepatide as a pill. They came up with a new drug called Foundeo, which is a GLP-1. And this is the data that they sort of pulled together in terms of changes of weight. And so as you can see, it's not quite as robust or impactful as both semaglutide or tirzepatide, but it's still pretty dang good, 15, 14%. It's, a lot of these medications need to be taken every day. And so that it is a little bit of a difference compared to the once a week subcutaneous injection. And we're getting a lot of questions about, should a patient switch from the injectable to the pill? Megan, how do you answer that question?
I think it depends on what the goals are, right? So how much weight do we want to lose? What are our weight goals? What are we using this for? What are our indications? But I think that, if a patient is doing well on their current regimen, I tend to not switch them. We tend to just kind of optimize the dosing to sort of maintain or keep them at their goal or get them to their goal. I think if we're having trouble with shots or insurance coverage, particularly, and we can talk about that in a second, but the pills are a reasonable option. And I think a lot of patients really like the pills because they do start at a cheaper price point if we're not getting insurance coverage. So.
And, going back to a little bit of that mood question, one of the things that we hear sometimes is that women, they need help maybe kind of reflecting on their hunger, and they need help with cravings, but they don't want to have a complete cutoff of their hunger and their hunger cues. And we find that maybe, the pill is this nice middle ground, because you have to remember, it kind of the levels rise and fall throughout the week versus if you take a subcutaneous injection, so it goes up and it's lasting all week, all through the weekend, right? And sometimes even longer than the 7 days that we sort of recommend the medication being given. And so for some patients, the ability to control some of that sort of overlay of those hunger cues can be really helpful. There was one study that came out this spring, and it looked at patients, both men and women, who had been on tirzepatide, had been doing well, were holding a weight, and then flipping them from tirzepatide to the oral pill. And a good chunk of patients were able to hold in weight maintenance. So it's not as though every patient, has to sort of stay on the medication forever. Some did well, but in our practice, we really tend to like patients to, if they're doing well, to sort of stay on track, because it can be hard, to have your weight sort of fluctuate back and forth. So one of the questions was about what happens if you start regaining weight. And a lot of this has to do with dosage and what type of medications you're on, and some of the backbone reasoning for why you sort of started gaining weight in the first place. So if you're a woman who's suffering from a lot of insulin resistance, PCOS, MASH, or fatty liver disease, we know that high insulin levels may really play a big impactful role on the reasons why you gain weight. A lot of the times the drugs like semaglutide and tirzepatide do help get some of that in track, but not always. And a lot of the times we still need to rely on strength training, cardiovascular fitness, and healthy diets to help sort of be the driving force behind, even further weight changes. We're going to talk a little bit about the new drugs coming out, but particularly for those women who are struggling with that high insulin, we're really sort of looking to the future about some of the other newer drugs that are coming out. So we can kind of move to that section. So the newest drug that's coming out, hopefully next year, is called retatrutide. If you look on the internet, everyone says they already have it, which is not true. There's a lot of like bodybuilders and things that like are injecting themselves with God only knows what.
Yeah.
So, we're looking forward to this extra drug. So what is retatrutide? Retatrutide is essentially what tirzepatide is. It's those two, GLP-1 and GIP, but it's this third molecule. And interestingly, this molecule is called glucagon. It comes from the pancreas. It's sort of the counterpoint to insulin. So, as your body is working through these messaging systems of processing blood sugar, insulin sort of rises as your blood sugar rises. But as your blood sugar falls, actually glucagon is supposed to go up. And it's part of that complex messaging system. Mm-hmm. And one of the things that is a theory is, when we think about high insulin levels, the theory was always that the high insulin level itself was a problem. But one of the theories is maybe it's not just a high insulin level, maybe it's a low glucagon level, and we're missing out on some of the energy effects that glucagon's providing. And so as you can see, if you're looking at the changes of body weight from this study, we're seeing even more weight loss, in addition to, with adding that glucagon, in addition, in comparison to tirzepatide. So in the studies, it was like 25% and sometimes even higher in some cases. And so, we're thinking about the women who are not losing weight on tirzepatide at all, which is a good chunk of women. We're thinking of women who maybe have started to regain massive amounts of weight, right? Maybe not necessarily 5-7 pounds, but we're talking about 15, 20 pounds, maybe them being a good candidate for retatrutide. And then the one group that I'm really sort of leaning into is probably those women who are struggling with metabolically associated steatotic hepatitis or MASH or fatty liver disease, because that is so important to get a handle on right away, because of that inflammation in our liver can be something that we don't know is going on and really be impactful down the way.
Mm-hmm. I agree. Yeah. And I'm excited for this too, in addition for, our patients who suffer from PMOS, formerly known as PCOS,
yes,
that high insulin resistance, driving that weight gain and those associated changes as well. So I'm really looking forward to this coming on market as well.
I think a lot of women are hearing so much about this. Again, we went from this way big whiplash to no one had any idea what semaglutide was. And we were doing a lot of education in the office to everyone knows what retatrutide is and wants to take it, right? Yeah. So we're in a completely different place. And, if you're a woman who's done really well on tirzepatide, meaning you lost 15, 20% more, I don't know if you're going to get much impact of switching from tirzepatide to retatrutide. And we'd be worried about cutting off really any further hunger cues, because we don't want that to go away completely. We really do still want to have some of this balance with eating. One of the things that I'm really hoping is we'll see further improvement to side effects. So what was interesting moving from semaglutide to tirzepatide is women tend to have less nausea, and they just overall felt better. And that's one of the reasons we tend to lean a bit more into tirzepatide, not so much that they're going to lose more weight, but mostly that women just tend to feel better. And we aren't 100% clear as to why that was. Who knows, with the addition of some of these other molecules, kind of what we'll see and feel.
Mm-hmm.
Okay, and then we're gonna, the other sort of next line up molecule that's gonna be available is something called an amylin analog. If we wanna flip to the other slide looking at amylin, so just like glucagon and insulin, amylin is secreted from our pancreas in response to eating. And just like the GLP-1s, it's part of this messaging system, and it's going to all these different places, our fat cells, our muscle, our liver, our brain, sort of to tell our body that we have food. One of the things that is in addition to, all this energy system, but amylin also hits at the amylin analogs also hit on the receptors that control some of our bone mass. And unlike other weight loss plans, we actually see an increase of bone mass. So we're really excited to introduce amylin analogs to this whole sort of world to see their role. Amylin analogs in general don't tend to have as much total body weight loss. And a lot of the times we think that they're going to be used in addition to some of the GLP-1s. And so what's coming out of something called CARGI-SEMA, which is the addition of an amylin analog and semaglutide. So very excited about that. The group of women that I think will be, really interesting to look at are those women who, have made it through, have survived breast cancer and are taking, estrogen blockers or no longer have estrogen in their system. And we worry so much about bone loss in those women. And we tend to see that they start gaining weight and have metabolic shifts. And so I'm really interested in seeing for that class of women, sort of the use of amylin analogs. And of course, we're looking at that as time goes on. Tracy asked, is there a risk for bone density loss? So for the amylin analogs, no, because they seem to sort of impact the bones at this one place. For some of the other medications, we're trying to understand that, I think, a little bit more closely. So as women age, we do tend to see a loss of bone, and it's unclear exactly what's driving that. Is it the poor nutrition as women are losing weight? Is it the shifts of our, hormones? Again, our fat cells are secreting estrogen. So as we lose sort of, as our fat cells shrink, are they secreting less estrogen that somehow is impacting the bone? Is it just physically less weight on our body? And we know that tug in our bones sort of, prevents bone loss. And so we're losing some of that structural friction that's there. It's hard to say. The other thing that we're finding is, a lot of these studies, when we first started out, we're measuring, they were comparing sort of different types of bone, like a body density. And they were sort of grouping together. Like they're like, well, there's fat and then there's everything else. And if everything else holds stable, then if one thing changes, it must be bone, right? And they were making these big sort of assumptions. And what we're finding is a lot of those times those assumptions aren't holding, because there's a lot of other basically mass changes with these GLP-1s that we've never seen before. Like, for instance, there's a lot of intramuscular fat. So it's not being registered as subcutaneous or visceral fat when we're doing some of these measurements, but it's intramuscular fat, and that is shrinking, and that may be contributing to the muscle mass loss that we're seeing, but it's actually not viable muscle. And one of the things that's really confusing is a lot of these patients, even though they're losing muscle mass by our measurements, tend to be substantially stronger. So, if, that's sort of this question that we're trying to answer is, how is it that, these patients may be losing muscle mass, but functionally the muscle is better? And we're not 100% sure why that is. Definitely when people go on really restricted diets, bariatric surgery, we see both bone mass and muscle mass loss. And so we're hoping that that's not always the case. And that's really why we lean into trying to get women to lose weight slowly and not necessarily lose weight at a really rapid rate, and trying to sort of, that slow and steady is way better, both for a variety of different reasons.
And same thing with the dosing recommendations, right? When we first started using GLP-1s with the recommendation and the guidelines to increase after a month or however long, to sort of titrate and maximize dosing, versus now I think the mindset is trying to maybe use the smallest dose that's appropriate for the patient to get the weight loss.
Yeah. And Ginger asked a question, how does low thyroid levels play in using GLP-1s such as Zepbound? So thyroid, our organ of thyroid, is very much at play in that whole messaging system. We see that women who struggle with hypothyroidism or low thyroid levels tend to gain weight. We see women who have high thyroid for a variety of different medical reasons. We see them that they're unable to keep weight on, right? And we see that they kind of thin out or their body fat really decreases. So, we know that our thyroid hormones are very much at play of this energy balance. We talk about thyroid for a couple of different reasons in the GLP-1 world. One is there's a black box warning on the GLP-1 label that is about medullary thyroid cancer, because some of the animals in the animal studies developed medullary thyroid cancer. There's sort of this big push to take that away because there has not been any increase of human thyroid cancer. And in fact, patients who have had other types of thyroid cancer, such as papillary thyroid cancer, we've started on these medications, and I've had patients that have been on them for years, and we're not seeing a recurrence of any type of, secondary thyroid cancer. So, thyroid cancer itself is not necessarily a contraindication, but that type medullary thyroid cancer would be.
Mm-hmm.
So that is one role of thyroid. The second role of thyroid is, because, when we take thyroid replacement, it really depends on the absorption through your GI tract. And what we're finding is that if you're using a GLP-1, you're retaining food longer in your GI tract. And so you may not be absorbing as much as your thyroid supplement as you had been before. And we really need to check those thyroid levels.
As your weight fluctuates and hopefully is reducing on a GLP-1 too, we've seen a lot that your thyroid supplementation needs to be adjusted as well. So that's one thing that I always tell patients. We need to be checking this a lot sooner and a lot more frequent than typical.
Yeah. So these are all great questions. We actually want to bring it back to Jennifer, and we want to talk about kind of what we do in our clinic. So we may talk to Jennifer about using a GLP-1. And the question we hear a lot is about timing. And so we just want to pull up one of the studies that looks at, in terms of use of these medications and timing around your phase of ovarian function. And one of the studies that looked at women using, tirzepatide at different phases of ovarian function, reproductive, perimenopausal, menopausal, and there did not appear to be a difference of timing. So, one theory was that because postmenopausal women struggle with so much metabolic syndrome and metabolic disorders with that loss of estrogen, that they may be more impacted with the use of tirzepatide as compared to younger women or women in a different phase of ovarian function. But actually, that was not the case. I was actually a little surprised by this.
Yeah, I was too.
Yeah. But what was, the counterpoint to that is we're going to pull up some of the that slide that looks at the use of menopausal hormonal therapy, and the same was true with semaglutide. There really was not a big difference. So, but what we did find is women who use both a GLP-1, both tirzepatide and semaglutide, in addition to their menopausal hormonal therapy, actually saw more weight loss in comparison to women just being on these drugs alone, which is really, crazy cool. Because that's a lot of the times what we do in our office is we're trying to get women sort of, that are good candidates for both menopausal hormonal therapy to treat all those symptoms that Jennifer was talking about, the irritability, the vaginal dryness, the night sweats, but also sort of tackle the metabolic aspects of this.
And I think this just speaks too on what we've been talking about as far as the intricacies and the complexity of weight and, the hormone piece and all of the pieces that sort of play together in the role of weight gain and why individuals struggle.
Yeah. So. As women lose estrogen is part of that whole communication system, but it's it's so multifactorial. It goes to our brain, and our brain can't, works, is not able to make as good of decisions about sweets and foods as it was before. It works at our liver and changes the sugar processing and lipid processing that our liver does. And very interestingly, it actually has a role in the GLP-1 receptors at our cells. And so as we lose estrogen, we have less GLP-1 response. So you may have the exact same level of GLP-1 in your body, but as you lose estrogen, your cells are not responding in the same way. So again, that may mean that we need a dose adjustment, or we just may need that addition now of a drug like a GLP-1 to help kind of create some of that balance, both with our blood sugars and fat loss. So, again, great conversations to have with your doctors.
Yeah.
Okay. And Valerie asked, what are your findings about staying with GLP-1s for a lifetime? I've had great success and no side effects. Would you recommend that for life? I think the data's out, Valerie, because, a lot of it, and mostly because of the anti-inflammatory effects, right? We find a ton of women who are doing well. They've lost weight. They feel great. They don't need to lose any more weight. They're confident, they're feeling confident with their bodies. They're really happy, but maybe they struggle with vascular disease. Maybe they're struggling with obstructive sleep apnea. And we're really, trying to actually treat that aspect of their health now, and not necessarily just to lose weight.
I would say, yeah, as long as you're staying within a healthy weight and other metabolic labs are staying healthy, yeah, I don't see a problem with this. So
yeah. And Ginger asked for clarification. So is semaglutide and tirzepatide ingredients included in different GLP-1 medications? So semaglutide is what is only in Ozempic and Wegovy. And then the drug tirzepatide is a completely different drug. And that's what makes up the drug Mounjaro and Zepbound. The two are not ever combined together. What makes them confusing is they're part of the same medication class. And so the side effect profiles are very similar. There's really not a difference in the different side effects between the two. Some of the impactfulness may vary. Like, as we said, people tend to have less nausea on tirzepatide, but people definitely still have nausea on tirzepatide. They sure do, right? So they're completely separate drugs, but they are part of the same class. One of the things that we're trying to understand is something that we call class effect. So meaning, can I apply the same results of weight loss co-conditions that got better to all the drugs? So semaglutide is FDA approved to help prevent secondary heart attacks, right? And tirzepatide is FDA approved to help improve obstructive sleep apnea. But can I say that semaglutide improves obstructive sleep apnea? And can I say tirzepatide maybe helps, improve lowers the risk of secondary heart attacks? The research purists would say no, that you're not allowed to do that because the data is not out. But it really feels hard to say if someone's gotten so much better and they have less inflammation, when you imply that that would also sort of go to every class of these drugs. I think we're really trying to understand that.
Yeah. Yeah. I'm excited for the future because for the first time in a long time, we have a lot of, it feels like, options and pathways here.
Yeah. And then Anne asked a question. I'm on, I never can pronounce this word, estrogen blocker for the past 2 years. How does this play a role in the use of these medications? So when you're on that medication, obviously your estrogen levels become low and your cells are not able to see estrogen in the same way as they did before. There should be no reason why you wouldn't be able to use these medications just because you were on an estrogen blocker. And if anything, it may be helpful at preventing some of the complications that we see come from estrogen blockers, such as the metabolic consequences at our liver and the expansion of some of our fat cells that we see as our estrogen level drops. So there would be no reason why you couldn't use those medications. The oncologists have been a little worried about use of these medications because they see people who can't eat at all from cancer treatments, and they don't want to add in another drug that's going to prevent someone from not eating. So they've been a little hesitant about, this combination use. But today, if you're doing well and you're able to eat and, you're able to get a good amount of nutrition and you're struggling with metabolic issues or weight, there'd be no reason why you shouldn't be able to use those drugs in combination.
I would agree.
Yeah. Thank you. A lot of great questions. We're going to move into our 5 tips. So we're kind of rounding up all of our questions about our little talk about GLP-1s. We hope this was very helpful and impactful about making some decisions. Okay, so our 5 tips. 1, it is not your fault. Even without changing anything in your life, you're going to start gaining weight during midlife due to hormonal and chemical changes in your body, despite your best efforts. Think back to Jennifer. She's right there along with all the rest of us.
Yes, she is.
All right. Number 2.
Name your goals for success.
So sometimes we find that, that number on the scale may not be your only goal, right? Sometimes the goal is just controlling your blood sugars. Sometimes the goal is controlling your food noise, right? Being able to drive by the gas station and not stop after work every day and grab a snack. That's okay to be a goal. Some women have the goal of just, looking in the mirror and feeling confident. That's okay too, no matter what that number is. So think about more than just that number on the scale.
Absolutely.
Number 3, so many options out there now.
So many.
Yeah. And of course, insurance and coverage sort of dictates a lot of our options. Don't be afraid to use some of the older oral anti-obesity drugs. A lot of them are cheap and easy, and they can be a really good first stepping stone as you're trying to figure out, the best way to get coverage for some of the GLP-1 medications. All right. Number 4. Go ahead, Megan.
Not everybody loses weight, and we know this, and it's not all about the weight, remember? So there's other benefits to this, and hang in there if you're struggling.
If you're one of those, it's totally not fair, and it feels so frustrating, but no, you're not alone.
I know.
All right. The future's bright. More things are coming out. So if you're one of those ladies who isn't losing weight, or you're not quite where you want to be, or you're struggling with extra food noise that has returned, there's all these different drugs that are coming out. I mean, we talked just about 2 sort of additions that are coming out probably in the next 12 months, but truly, guys, there's like 20 or 30 different drugs that are going to be available, and this world is going to be very exciting.
Yeah. And hopefully, like we talked earlier, coverage will be better, fingers crossed, but we keep advocating. So we hope so.
I couldn't stick with 5. I had to do one more. Number 6. Despite medications, you still want to work on how do I get these healthy aspects in healthy lifestyle changes into my life? How can I get in exercise? How can I learn to sleep better and not have so much stress? We talk about in our practice as being seeds, but truly those things are really the backbone of both a menopausal plan and any weight management plan. And we don't want people to forget that that those things are still an option as part of changes.
Absolutely.
All right. So if you are not in the great state of Michigan and you need to go bring some of this information to your doctor, here are 5 tips to take to your doctor. What is my phase of ovarian function? It's like our favorite question to ask in our true office.
Yeah.
Why is that important? So your phase of ovarian function is essentially a reflection of how much estrogen you're naturally making. And I hope we've hammered this in, that estrogen is so impactful in your body's decision to, gain or lose weight and impact our lipids that are our blood fats and our blood sugars that are floating around. And you need to know how much estrogen you have floating around. So it's really important to know. Forever, we sort of rely on your menstrual bleeding, but you can ask to get labs if you can't rely on that, such as you had a hysterectomy or you have an IUD.
Absolutely.
All right. Number 2.
What is your experience with using anti-obesity medications? It's fair to ask, and it's fair to request consultation with somebody who is comfortable if your provider is not.
Yeah. Not only that, but, you really want to make sure doctors are humans and we all have biases just like everyone else. And we really want to make sure that, you're not working with a doctor who maybe has a bias against anti-obesity medications. We hear this a lot for women who come to see us, that their doctor just flat out won't write for these drugs, which is really not what the data is showing. I mean, it's borderline unethical, honestly, because of just the massive changes in both weight, anti-inflammatory, and disease processes. So even though maybe your doctor feels that the use of these medications is what they don't believe is appropriate, that still is your right to be able to find them. And at least if you can get coverage and whatever, have that be part of your decision tree.
Mm-hmm.
You can always go to the American Board of Obesity Medicine and find a provider in your area by zip code. And that can be really helpful if you're looking for someone who has a little bit more experience.
Mm-hmm.
All right, number 3.
What are my options for menopausal hormone therapy?
Again, a lot of doctors are biased against menopausal therapy, although I think that's changed a lot over the last 2 to 3 years or so. So make sure you have a doctor who provides you with some options. There's oral options, there's patches. There's a lot of different ways to get some menopausal hormonal therapy. So make sure you have a doctor who's open to that.
Absolutely. And again, menopause.org, if your provider doesn't feel comfortable with providing that information to you, you can also search by zip code for a provider who is menopause certified and maybe in your area that could help you out.
Great. Number 4.
What are some of my resources for support?
So you may need a dietitian, right? Like if you're really not hungry, but you need more protein or more fiber, you may need a dietitian for support. If you're struggling with knee pain, back pain, and that's really limiting your exercise, let's find you a physical therapist, right? You really lean into some of these tools that are available to sort of optimize both, management of side effects and, working on towards some of those lifestyle goals that we have.
Mm-hmm. Absolutely. We always ask our patients, what are your barriers, so we can help break those down. So,
yeah.
Mm-hmm.
Number 5.
And we have frequent check-ins.
So we really, in our practice, we found the way that this goes the best is if we check in pretty frequently with patients. You never know how a patient's going to do on these medications. I've had some patients that have started it and started vomiting. I've had patients who have started it and don't feel a thing and don't lose a pound and don't even know if they're taking it, and everywhere in between. Mm-hmm. So it's really important to have check-ins with someone who understands this dosing and, make sure that you're not just without thought going up and up and up on the dose, and really making sure you're getting in enough nutrition.
Absolutely.
All right. That was our summary of GLP-1s. We hope, in a couple of months that we can talk a little bit more about retatrutide and our experience with that as it becomes available. As always, we're here to answer questions, and we're available to help manage, women's health for women 18 and up. Check us out at truemanshealth.com.
Thank you, guys.
Thanks.